sorry, the level of the patient that didn't increase the amount of recombinant FSH, but they only add recombinant LH at a significant more estradiol level, and the number of oocytes also was higher in this patient. Actually, they had more implantation rate, but it was not, if you compare it to the other group, but it was not significant statistically. Of course, there were more oocytes in the control group, and also estradiol level was also higher in the control group, but of course, that's what we suspect it would be. So their conclusion was that r-hLH, recombinant LH supplementation is more effective than increasing dose of recombinant FSH in terms of ovarian outcome in patients with initial inadequate ovarian response to recombinant FSH alone. Another paper in 2004 in fertility sterility also tried to see that patients with hyporesponsiveness to recombinant FSH, how they react to the recombinant LH. In this paper, out of the 1,000 patients, 130 patients didn't respond well, and then they divided to a few groups. Group 1 increased the doses of FSH. Group B, they added recombinant LH and also increased the doses of LH. And Group C used additional of FSH and LH using human menopausal gonadotropin, and they compare it to age-matched control normal responder. And what they showed in the result is that the groups that received recombinant LH had more oocyte than the group that only increased the recombinant FSH, and they also had more oocyte, even though only small difference from the group that got HMG. And also the pregnancy rate was pretty impressive if we compare it to both groups, the group that increased the recombinant FSH and the group that got HMG. Okay, which is definitely impressive. And again, their conclusion was that an hyporesponsive patient to FSH that may be related to iatrogenic LH deficiency, and therefore it affects the oocyte competence, and addition small amount of recombinant LH is able to rescue the oocyte competence to produce viable embryos. And again, LH may be beneficial in poor responder. There was a Cochrane in 2007 that tried to find in poor responder what is more beneficial, recombinant FSH alone versus recombinant LH and recombinant FSH. And we can see here that there is a trend toward recombinant FSH and recombinant LH in the pregnancy rate. And basically, the conclusion is then in poor ovarian reserve and hyporesponsive patient, the adding of recombinant LH may be beneficial for them. So the next question is maybe using recombinant LH according to the woman age. A paper in 2004, you may then try to see if in patient older than 38 years, what he did, he gave in long protocol the first 8 days only recombinant FSH, and then since day 9 of stimulation, in half of the patient, he added the recombinant LH. And again, if we look at the pregnancy rate, we see that there was 33 pregnancy rate comparing to 22 with statistical significance. And if we look for the implantation rate also, we see a marked increase again in the patient that older than 35, 36 implantation rate compared to only 13. But if we look at the patient that younger than 35, we don't see any difference between the patient that got recombinant lH and those that didn't. In 2011, again, Hill tried to look for using recombinant luteal hormone in patient going IVF with an advanced reproductive age. He did a meta-analysis to see what are the results. And again, if he took all the manuscription, that some of them I mentioned here, like Humidian, he showed that the implantation rate is higher when you use recombinant FSH in this sub-selected group of patients. And if you're looking about the clinical pregnancy, again, we see that there is a trend toward adding recombinant LH in those patients. So the conclusion is that the addition of recombinant LH to ART cycle may be improve implantation and clinical pregnancy in patients of advanced reproductive age. So the summary is that patients older than 35 years may enjoy the adding of recombinant LH. And you can do it with lower total recombinant FSH. You have higher implantation rate and higher pregnancy rate. In 2010, a group from Italy published a paper that tried to compare urinary agege versus recombinant FSH and recombinant LH, Pergoveris in IVF. It was a multicenter prospective randomized controlled trial. They had 125 patients in long protocol. Group A received urinary HMG, and Group B received Pergoveris, which is the recombinant FSH and recombinant LH. Sorry for the quality of this slide. So if we look in, all the parameters are equal, and the only difference that there was a statistical significance, more OHSS in Group B, the group that received the Pergoveris. So the conclusion is that treatment with AMG or with recombinant FSH plus recombinant LH could achieve the same result in terms of pregnancy rate, implantation rate, and embryo quality, but we find there was a statistical difference a little bit in oocyte quality. So if we conclude the lecture, Pergoveris is found to be efficient in selected ART population, not in non-selected. The group that may benefit from it are poor responder, a patient over 35, and of course hypogonadotropic hypogonadism that of course they lack the LH. But more studies should be done to compare the efficiency of Pergoveris and HMG, because we all know that Pergoveris, because it's recombinant, is much more expensive than the HMGs. So we have to see if there is advantage of this price to compare to HMG. So otherwise, I'm not sure if it is necessary to use such expensive medication if we have the same result with the less expensive one. Okay, thank you.
In the earlier studies, you didn't show the rate of ovarian hyperstimulation, although you showed good pregnancy rates with the Pergoveris rather than recombinant FSH in the Italian study and Ferrati study. Although with Meropur you showed that Pergoveris had a much higher ovarian stimulation rate as compared to Meropur. So that is one drawback. Another thing you commented that it may be useful for hypogonadotropic hypogonadism. Now with the coming of kisspeptins, don't you think that kisspeptins may be a better choice rather than us going for more and more gonadotropins? Kisspeptins 10 are being tried more and more because GPR54 mutations, kisspeptins upstream of GnRH, and it has been found that kisspeptin 10 may be a better alternative for hypogonadism rather than just using simple gonadotropins. Kisspeptins are normally the analogs which act on kisspeptin receptors. See, these were accidentally discovered as analogs when hypogonadotropic hypogonadism was discovered in some genetic mutations for GPR54 receptor deficiencies. There were 2 patients who were diagnosed by Professor D. Rox from France and simultaneously another professor. Recently, then neurokinin B receptor deficiencies have been found. Then TAC receptor deficiencies. Kisspeptin is a peptide which acts on this GPR54, and it is the one which stimulates the gonadotropin releasing hormone stimulation. It is responsible for puberty normally occurring, and GnRH stimulation so that puberty normally occurs. And normally for the GnRH surge to occur, kisspeptins are very essential. I have just written an article in the Journal of Assisted Reproduction, which will be coming in this month. Dosage of kisspeptin 10, again it is in micrograms levels. It is still in experimental stage. It is, initially it was used subcutaneously, so tachyphylaxis developed. So now they are trying to use it at much lower dose and initially it was tried only in animals. Human experiments are going on. It is still in phase 2 and phase 4 trials.
Because we've got data comparing it with HMG. It'd be interesting to know, because Pergoveris is, in terms of cost, if we're going to say there's really a benefit, then we should compare it with Luveris as well and see how does it compare. And overall, if we're saying it's got equivalent pregnancy rates, I agree to your comment about the cost, but it'd be interesting to know that in some places we're not getting Pergoveris, so what about Luveris, and how does that translate into clinical practice?
That's a good question, and also I didn't find many papers that compared HMG and Pergoveris. For some reason, I guess, nobody, the company don't like to do such comparison, because I showed it's the same, so what is the point?
This one has both. Luveris is just recombinant LH and one.
But the recombinant LH is Luveris. It's the same company. So.
But
yeah,
I would say just compare
they assume that it's like you give recombinant FSH and then
Another thing, I came on a beautiful article where Professor B.C. and Fosser had reviewed on even simple hypogonadotropic hypogonadism, where they had just used plain recombinant FSH and hypogonadotropic hypogonadism had got treated. So even that questions are 2-cell 2 gonadotropin theory. So means that was my question to Professor Hassan as well yesterday, that whether all hypogonadotropic hypogonadism are not Kalmans. In simple hypogonadotropic hypogonadism, Professor B.C. and Fosser reviewed a beautiful article. He had quoted at least 10 to 15 cases of hypogonadotropic hypogonadism, where he had used plain, where there were articles he had quoted, where plain recombinant FSH had been used, and hypogonadotropic hypogonadism, good follicles had formed and conception had occurred.
And good estradiol level also.
Yes.
So I guess they are
so that's
not
why
100%.
So I said that challenges are 2-cell 2 gonadotropin theory hypothesis as well.
It's interesting, yeah.